Thank you, Dustin. Excellent. Our next speaker is Dr. Amber Makani, who is going to share with us her thoughts about the multitude of valves that we have currently available. How are we going to make sense of who to use these in, and what are the pros and cons of each? Thank you. Dr. Makani.
Good morning. Thank you guys so much for having me. So today I'm going to discuss valve selection in TAVR. How do we decide? I have no relevant financial disclosures. So the population of patients who are receiving TAVR in the United States continues to grow. As you can see, in 2015, TAVR surpassed isolated SAVRs, and the rate continued to dramatically increase. And in 2018, we saw that the rate of TAVR implantation in the United States surpassed all SAVRs. Looking at the mean age of patients receiving TAVR in the United States, comparing those patients in 2013 versus currently, you can see that there's a general decrease in the average age of patients who are receiving TAVR, and we expect that this is a large contributor to the increased volume of TAVR implantation in the U.S. And so our traditional focus has been around immediate cure. So we've been treating typically patients who are 80 years old. These are patients who have limited functional capacity and typically a trileaflet anatomy. And our focus has been mortality rate, decreasing our stroke risk, evaluating pacemaker needs, and the quality of life. But as we continue to treat younger patients, there's a little bit of shift of our evolution of focus to lifetime management, as Dustin mentioned. We're treating younger patients who are 60 plus. These patients are more active, and they have variable anatomy. So our focus is now about durability for increased longevity, optimal hemodynamics, consideration of valve-in-valve TAVR, and coronary access. Going through the typical valves that we use, so there are multiple iterations of the balloon expandable Edwards valve and the SAPIEN 3 Ultra you see on the right side as our current iteration. In terms of self-expanding TAVR valves, there are multiple iterations of the Medtronic valve as well, and the current Evolut FX. And the Abbott valve has kind of evolved into the current generation of Navitor. So different ways to look at these valves. So we often talk about intraannular valves versus supraannular valves. You can see that the Edwards SAPIEN and the Abbott Navitor valves are both intraannular valves versus the Medtronic valve being a supraannular valve, high versus low radial strength. And lastly, not that it's at the forefront of our minds, but something to keep in mind is the cost. So there's two sides of a coin here. We often have to balance complications with management considerations. And the complications include things like permanent pacemaker, paravalvular leak, stroke, coronary obstruction, annular rupture, as well as vascular complications. And the management considerations, we often are looking at optimizing the hemodynamics, long-term durability, looking at bicuspid valve disease, as well as coronary reaccess. And the things that, unfortunately 10 minutes is not enough time to talk about all of this, but I was just going to kind of highlight a few aspects here. So we'll talk about a little bit of both sides here. So unfortunately, as Dustin kind of alluded to, we have no large randomized head-to-head trials for current generation of TAVR valves. And we're awaiting data regarding the SMART trial in those patients who are randomized with small annuli to the Evolut versus the SAPIEN valve. So looking at conduction abnormalities, this is the PARTNER 3 trial that evaluated transcatheter aortic valve replacement in balloon expandable valves in low-risk patients. You can see that on average, the new pacemaker rate here is fairly small at 7.3%, but still greater than those patients who receive surgery. Notably, though, there's a new left bundle branch block that has been shown to have other implications in about 23% of patients. Looking at the Medtronic valve, so in 2014, the ADVANCE study showed that the average pacemaker implantation rate in patients who are receiving the core valve was approximately 26%. Hemel and his team have been incredibly successful in dramatically decreasing the pacemaker implantation rate for self-expanding valves. You can see that prior to the implementation of cusp overlap, the average pacemaker implantation rate was about 20 to 26%. And looking at the interim analysis of the optimized pro data that was presented at TVT in 2021, the pacemaker implantation rate is now somewhere right around 8.8%. And Hemel's team has actually shown even lower rates in their personal data. So evaluating paravalvular leak, this is in the Observant 2 study, which evaluated patients who received the iterations of the self-expanding as well as balloon expandable valves as listed. You can see on the left side of the figure there's mean gradients that are listed, and on the right side paravalvular leak. So typically what we found is that self-expanding valves have lower mean gradients versus the SAPIEN typically has a higher mean gradient, but there's a little bit of a trade-off when we're looking at paravalvular regurgitation, as those patients who receive a SAPIEN valve were noted to have lower rates of paravalvular regurgitation than those patients who received a self-expanding valve. Looking at patient prosthesis mismatch, so this is from the SES ACC the TVT registry, and so this is looking at all comer patients treated with TAVR between 2014 and 2017, and what you can see is that there's multiple risk factors for patient prosthesis mismatch, including a valve size less than 23 millimeters, valve and valve TAVR, and things like body surface area, age, female sex, as well as multiple other factors that are listed. And on the right, you see the breakdown of patients who typically have patient prosthesis mismatch. And thankfully, this is not a frequent occurrence, but on the figure that's on the far right, you can see that in those patients who have severe patient prosthesis mismatch, even at 1 year, there's increased mortality in comparison to those who do not. Looking at hemodynamics, so this is hot off the press from our institution. This is an analysis completed by Jake Brown, one of our cardiac surgery residents, as well as Dr. Sultan. And what you can see is that across the board, the dimensionless index is higher immediately post-TAVR, and there's a mild reduction that is fairly insignificant in the self-expanding valves that is more pronounced in those patients who received a SAPIEN valve. This figure depicts the mean gradients. Kind of similar to what's well published is that on the day of the TAVI, we see decreased gradients overall in all valves that are implanted. For the self-expanding valves, the Portico as well as the Evolute, you see that there's a transient increase on day 1, but ultimately this gradient decreases at 30-day follow-up. In those patients who received the balloon expandable SAPIEN valve, they had gradients that were elevated at day 1 that were fairly persistently elevated even at day 30. On the right, you can see the comparison of mean gradient between the valves, and the red line on top is the SAPIEN valve, as we mentioned, increased gradients that are fairly persistent. And on the bottom, you see the superimposed lines demonstrate the Abbott Portico as well as the Medtronic Evolute valve, and this really proves that the Abbott Portico valve, despite being an intraannular valve, really does have similar gradients to the supraannular Medtronic Evolute valve. So lastly, looking at structural valve deterioration, I know that Dustin showed some of this data, so just to kind of skim through it briefly, this is the 8-year follow-up for the NOTION trial on the left that shows overall that the TAVI valve has less structural valve deterioration in comparison to SAVR valves. And you can see the definition of structural valve deterioration listed. When we look at the follow-up of the PARTNER 2 trial, we see that the current, or the SAPIEN 3 has significantly lower rates of structural valve deterioration in comparison to SAPIEN XT, but notably, the SAPIEN 3 valve still has higher rates of valve deterioration in comparison to surgical valves. So generalized considerations here. So the current literature has shown that there's lower mean gradients and larger effective orifice area traditionally in supraannular valves. However, our data and our experience seems to suggest that both self-expanding valve platforms have similar mean gradients. The long-term durability beyond 6 to 8 years has not been well established for any valve platform. The incidence and degree of PVL varies between the devices and based on the calcification and as well as the implantation technique. But in general, moderate and severe PVL incidence has decreased with the current generation of TAVR valves that we use currently. For valve-in-valve TAVR, optimal device selection requires us to really identify what is the mechanism that the initial valve failed, whether this is patient prosthesis mismatch, structural valve degeneration, or both. If it's patient prosthesis mismatch, a self-expanding valve may be more favorable in small bioprosthetic prostheses. And balloon fracture of certain prosthetic valves may also facilitate TAVR with larger device for better orifice areas. So our take-home points here, there's really no clear algorithm for valve selection. Each patient must be considered on a case-by-case basis. Considerations include the patient age, their calcium burden, coronary artery disease, valve morphology, as well as durability. But what I can say is what we found is in patients with angulated roots, bicuspid aortic valve disease, extremely large annuli, and beyond manufacturer recommendations, typically a SAPIEN valve is a good choice. In younger patients, consider a use of an intraannular valve. Patients with coronary artery disease, consider an intraannular valve as well. And for valve-in-valve TAVR, consider a self-expanding valve. Thank you so much.